name is Jeff Rossman, the Associate Director of the Mailman Center, and I'm a pediatrician here. It's great to have you guys here. The room will keep filling up. We'll try not to be distracted as people come in for our grand rounds. This is our second Mailman Center grand rounds. The first one was Children's Trust about a month ago. We have two more coming up before the end of the year, one from the Department of Health and one from the Miami-Dade County Public Schools. And the idea of our first set of grand rounds has been to take a broad view of child health, particularly children with special health care needs and developmental disabilities, and see how it all fits together. The Mailman Center in particular is trying to figure out how best to place ourselves in this broader context. It is Halloween. This broader context of child health in our community. And so we're extremely pleased to have our director of the Mailman Center, Dr. Danny Armstrong. He pleaded with me not to go through his entire resume, which would take up half of the morning's talk. But he's trained as a pediatric psychologist, but has then since taken on a number of leadership roles here in the Department of Pediatrics, at Holtz Children's Hospital, in the School of Medicine as the interim Dean of Faculty Affairs, and has a number of state and national roles. Danny was very involved in passing the dollar tax on cigarettes, which has reduced smoking deaths in the state of Florida. And because of that and other work, has won the Volunteer Award from the American Cancer Society, and is actually on the board of directors, which is a pretty remarkable thing. So Danny's going to talk to us about what's happening in child health, and specifically how that's related to Mailman Center and our future as an institution. So please join me in welcoming Dr. Armstrong.
I told him he could just say, "Here's Johnny," and we'd be okay. For those of you who are here interviewing today, we're really glad you're here. For those of you who come to this room quite frequently, you'll notice that we've got a great renovation, but it's still pretty cold. But I am assured by physical plant that the heat is going into the building for the first time in 45 years. So we should be warmer in the near future. I get an opportunity to talk a lot of times about the specifics of the research that I'm doing, and those are always really fun and exciting kinds of things to do. But you know, sometimes when you're the director, you get to go to 30 or 50,000 feet and wax eloquently about what you think the world is going to be like, and that's what this is about today. The Mailman Center has been a program of the University of Miami. It was the first university center. It is the only center at the university that is designated in federal statute, and it has had a really rich history, and I'll talk about that for just a minute, or in just a minute. But as we move through what we're doing, we're in the middle of a change, and most of you are trainees from one field or another, and occasionally I meet with our pediatric residents to talk about the future of pediatrics and the future of child health. And I'd like to see a show of hands. How many of you believe at the bottom of your heart that in 10 years you will be doing what you're being trained to do today? You probably won't. You probably won't. Because as we look at the things at the speed at which the field of healthcare is changing, things are going to be different. And as I think about the 30 years that I've been here, what I was doing 30 years ago, I don't do anymore. And my trainees don't do anymore. And the faculty don't do anymore. And whether you are a specialist or a general pediatrician or a psychologist or an audiologist or whatever, the world is changing. And so I'm going to talk a little bit about what we're trying to do here at Mailman to prepare for those kinds of changes and perhaps provide a little inspirational thinking so that you come out of your training as well prepared as you possibly can be, but ready to adapt to what the future is likely to be. I've never been a big person for vision statements and mission statements. They're usually required for an organization, but we've gone through a strategic planning process. We've come up with a vision statement. You're going to see this several times. One of the things I've learned about education is if you want to have a take-home message, you repeat it several times. You're going to see this one repeated. Our vision is to improve lives through innovation, impact, and connection. And I'm going to talk about why we've selected that and where it's going and how it fits into this broader perspective. And recognizing that our mission statement for the Mailman Center includes core components. It's interdisciplinary collaboration, focus on cultural competence, family-centered perspectives, and integrated mechanisms of research, training, service, and advocacy to address, develop, identify, integrate, and educate related to developmental disabilities and children with special health care needs. And that's our simple mission of what we're all about. This is a very storied institution. For those of you who are our trainees and haven't heard this, and those from out of town who are visiting, it's a pretty incredible place. It started because of a tennis match in Hyannisport, Massachusetts on the Cape. And the two players were the chair of pediatrics from Johns Hopkins and Eunice Kennedy Shriver. They were playing tennis. Mrs. Shriver had been pushing her brother, who you might know or not know was President John Kennedy, to lead legislation and create the National Institutes of Child Health and Human Development so that there would be a mechanism for research on what was called at that time mental retardation. Bob Cook, who was the chair of pediatrics at Hopkins, had children of his own who had developmental disabilities, and they were playing this tennis game one day, and I've talked to both of them. I had the fortunate opportunity to speak with both of them about this tennis game at different points in time. Mrs. Shriver assured me that she was beating Dr. Cook handily, and he said that he was beating her, but no one should beat Eunice Kennedy Shriver. And so they came to the net, and he said, you know, if you're going to do all this stuff and move people with developmental disabilities into community settings, you don't have a workforce, and you're going to need to train a workforce. And over that tennis net was created the concept of the university-affiliated facility, which was this building, one of the original 11 funded by the federal government and the Joseph P. Kennedy Foundation and the Abraham and Joseph Mailman family. And it was built purely to train a multidisciplinary team of, or group of students to be able to take care of people with developmental disabilities in community settings. That's why it all came about. And this picture in the corner is the Mailman Center in 1972, before we had the Metro Rail and a variety of other things that had a little reflecting pond outside. It was really beautiful. Sam Giamomo was the first director. Fred Richardson was the second director. And at the opening of the center in 1972, Mrs. Shriver was here, seated next to someone that, if you are aware of your developmental history, Jean Piaget, the real father of cognitive development in children. And Dr. Piaget was our keynote speaker that day. Now, I've put somebody here in the middle that you'll look at and go, who is Mrs. Lane Coleman? Well, Mrs. Lane Coleman embodies the passion that has developed around this center for the last 45 years. Mrs. Coleman is the mother of one of our current employees, Michael Coleman. Michael is an individual with a developmental disability who's been here for most of those 40 years. Mrs. Coleman was the executive secretary for President Henry King Stanford, who was the president of the University of Miami, when the Mailman Center was opened. Now, you can imagine that's a pretty important job. She was passionately committed to this center, and she embodied what I would call the innovation component of where we're at. Because you may or may not have noticed, those of you coming in from out of town may not have realized this, but when you come into Miami on a plane, there's about a 60% chance that you're going to fly right across the top of this building. And when you do, those jets make a lot of noise. Mrs. Coleman recognized that we were having Senator Ted Kennedy, Mrs. Shriver, Jean Piaget, these dignitaries from all over the country here for this thing, and she did not want the opening of this building to be messed up because of airplanes. And so she picked up the phone, she called the director of the Miami International Airport, and she said, please divert traffic for 3 hours. And they did. I feature Mrs. Coleman because that level of innovation and passion is part of the history of this center and why we do a lot of things that we do. Over the years, we've made a difference, and the innovation and impact has been part of our history. Herb Loves was a director of genetics program here. Herb received the Kennedy Award because he was the person who mapped out and described the relationship between the fragile X chromosome and fragile X syndrome as the major contributor to mental retardation. And this was in the 1960s. Charlie Bauer, who directs our Early Steps program and has been here for many years, was also the principal investigator of the Infant Health and Development Study that really followed the development of children who were coming out of the neonatal intensive care units due to small for gestational age, prematurity, and other kinds of factors. And Charlie was a leader of that study that helped us to really understand the developmental outcomes in that population. Kim Aller and Rebecca Eiler were two investigators here working at the Debbie School. And the picture on the side, this was before we had cochlear implants, and children who were deaf couldn't speak. And so they developed this little device that's hanging around the necks of these children. And what it was a pattern that when sound would come in, it would differentially vibrate across the belly. And they were able to use that as a behavioral shaping technique to teach children who couldn't hear to speak. And it was one of the early impacts in oral development. Rebecca Fuel, who was here for a number of years, was one of the initial leaders in the concept of inclusion, something we embrace and education programs develop. But here at the Debbie School, we were one of the leaders of the program that said, maybe we ought to take children with developmental disabilities and provide them with education experiences with children who are typically developing. It was a novel concept. It was also one that was that some people didn't like it. We had a lot of problems here when the HIV epidemic came through because parents started saying, well, I'm not sure I want my children in a classroom where another child might have HIV. We didn't know who had it. We resolved the issue, but what we also found is that while this was a phenomenally beneficial approach for children with developmental disabilities, it also had tremendous benefits for children who were typically developing. And they, as they progressed through school, we found that they were more socially sensitive and less aggressive and more socially engaging and respectful of diversity. And so there were some real benefits of Rebecca's inclusion model. Walter Lambert has been one of our leaders. He is the interim state director for the child protection programs now. Walter has been a real leader in understanding how we address and try to prevent child abuse. Michelle Sadat is our assistant director of the Mailman Center. Her work in developing integrated web-based planning using technology for training has been incredible. Barbara Bonner developed a web-based program called Project ABCs for dealing with babies. Tiffany Field. At one point in time, Tiffany is a developmental psychologist trained with Barry Brazelton. Tiffany was probably the most well-known scientist in our department. She worked with a colleague at Duke. They did a simple basic science study. This was really one of the first real good examples of translational science. Tiffany and her colleague took premature rat pups and randomly assigned them to either cage as normal or they came in with little paintbrushes and massaged the backs of the premature pups. What they found was that the pups that got massaged ate more, grew faster, and had less mortality. And that translated into a study here that was funded by the NIH, the infant massage study, where instead of taking these premature, small for gestational, 1,000-gram and under babies and keeping them in the incubators and never touching them, a team came in and did massage, not quite with paintbrushes, but it was a special infant massage team in our neonatal intensive care unit. And guess what they found? Typical discharge 4 days early, grew faster, fewer complications. And that translated into real community impact. Have you ever heard of kangarooing? It's a fad. It became a fad, it became a standard. That one piece of research out of this center changed the practice in neonatal centers all over the world. So we're talking about high impact. Alan Delamater, who is here, has been one of the leaders in the world. He's received national awards for his work looking at behavioral intervention with families and children, particularly Hispanic families, to be able to prevent the onset of type 1 diabetes. Our work in chronic illness has focused on understanding the effects of disease and treatment and outcomes. And Jeff Brosco and Michelle Schladant and Shelley Baer have created a unique training program here for individuals in the community to come in and become emerging leaders in developmental disabilities. And so we're really excited about what has been a phenomenal history of innovation. We've been well funded. This is just an idea of showing when we looked at this in 1999, our funding was at about, our total funding was at about $5 million. As you can see today, over the last 15 years, we've gotten up to about 25, 26 million. And so we've been very successful on that particular metric that we look at in terms of science. But there are challenges that we face today that we have to be able to address. In the field of special healthcare needs, as we look at changes that are taking place in the overall healthcare environment, prevention with intention is often missing. We respond to acute issues, but we're not necessarily intentionally trying to not have them happen. And so we do know that in some particular groups, we have elevated incidence of mortality and morbidity in selected minority populations. Here in Miami, we know that is in African-American children in certain communities under the age of 1. And so we are funded with Connie Morrow and the group to be able to intervene at a community level to reduce that mortality before the first birthday. Child abuse is a critical issue, but child abuse prevention is even more important. And being able to understand some factors such as extreme poverty and how those affect development. There's some interesting research that was just released this last week that talked about how much benefit changing the financial situation of families had on child development, child performance, and academic achievement. And we've talked about that. It is seen as an unmodifiable contributor to child health that could be modified if we had the will and the resources and the innovation. Domestic violence is a contributor. Involvement with juvenile justice is a critical issue. Data suggests that as many as 65% of children who are in the juvenile justice system have a developmental disability that was never diagnosed or addressed. And so there's opportunities. We don't think about developmental disabilities in jails, but that's an opportunity for intervention and prevention. And then as we look at models for of funding for early intervention and early detection, and the degree to which we are able to do that, we don't know whether we're providing adequate services or even appropriate services or most effective services. And so that's an area of tremendous opportunity for us. When we move to behavioral and developmental services, the whole issue of child mental health kind of falls off the chart because people have given up on it. Jeff and I conducted a study about 40 years ago, Jeff, it seems like, just looking at 3-year-olds in federally qualified child care centers and asking their parents to give us indications of their perceptions of problems in a number of child health dimensions. One of them was behavioral and developmental health. And when we followed up, it didn't crack the top 10 right off the bat because parents said there was nothing that they could do about it, so they didn't even talk about it anymore. It was a huge problem for us, and it is a national problem, and it's characterized by something nationwide. There are more than 12 million children who meet the criteria for a DSM-5 diagnosis of a mental health or behavioral health disorder. In the United States, there are less than 4,000 behavioral mental health professionals who have specific training and expertise in child behavioral and emotional health. That includes psychologists, school psychologists, psychiatrists, developmental behavioral pediatricians, nurses of a variety of different areas. And if you do the quick division, I like math, 4,000 into 12 million means that each provider would have a caseload of 3,000 patients. That's unbelievable. And that doesn't include children who aren't in the diagnostic category but fall into risk. the risk for a complication of a family disruption that doesn't meet the diagnostic level, children who have complications secondary to other health conditions. So this is a crisis area. And when you look at national websites, for more than 15 years, the Academy of Child and Adolescent Psychiatry has had on their website that they have a workforce emergency. Congress has recognized that there are workforce emergencies in this particular set of skills, and we can address it rapidly. When we look at developmental disability services and genetics, the challenges are huge. Newborn screening panels are fortunately in place for about a little bit over 30 conditions that have treatment available. And there are screening tests that are being developed for many others, but treatment is not available, so newborn screening early diagnosis isn't available. Laboratories for biochemical and molecular confirmatory testing are geographically limited and generally not sustainable because of the cost. There's just no way to be able to pay for it unless you take it out of some other pot. And there's a national shortage of genetic counselors. They're poorly compensated and they have no consistent funding source. And I started by saying, do you think you'll be practicing the way you did in 10 years as you're being trained now? This is the genetics lab here at the Mailman Center in 1980. It's a little bit different from high throughput genomic centers that we're looking at now. Life has changed. Oral health is another major unaddressed area in child health. Pediatric dental care, both preventive and restorative, is severely limited. We have nationwide children who wind up having dental caries that are never addressed. And every year in the U.S., there are 8 to 10 children who die because of oral health complications, an abscess that leaks into the brain and results in death. And when we begin to think about children with developmental disabilities, the special skills necessary to take care of those children, the behavior problems around them, the ability to provide sedation services, need to go into operating rooms, and the number of dentists who are actually interested in dealing with all the hassles are really, really limited. And so we've got an oral health challenge. When we think about other developmental services, the therapies, physical therapy, occupational therapy, speech pathology, speech therapy, there is continued downward pressure from funders to reduce the number of sessions that are paid for and to cut the cost. It's really interesting. There's been a flip-flop recently in physical therapy for a long time. If you ever had a back problem or a knee problem and you went to see a sports medicine or an orthopedist, the first thing they wound up doing is, well, let's wait 6 weeks before we do an MRI and let's put some ice on it and let me have you go see a physical therapist. And so you start with physical therapy. And then you get your MRI and you find out you've got a disc problem or your meniscus is torn or whatever. And then finally they come into authorization for services. And the concept was this was a financial model to be able to do less invasive and less costly intervention. Well, now the insurance companies have noticed recently that physical therapy is costing a lot of money, and so they're starting to deny that and moving the direction of care in a different direction. But when it comes to children with developmental services, the availability, the diagnosis, and the adequacy of the treatment is coming under real problems. In our community, there's another issue, and this is true in other major communities, and that is there are real shortages of therapists, particularly in the speech and language area where we are looking at bilingual. So if you speak Spanish or Creole or Hmong, and you have a developmental disability, you may not be able to get treatment because there's nobody there with the competence to be able to provide it to you. And so there's a real issue. And then for some of the programs, the infrastructure costs are huge. We think about physical and occupational therapy. The good physical therapy program is going to require around 2,000 square feet of space. A gait center is going to require all the technology for doing biometric analysis using infrared technology and videotaping. Very, very expensive when the reimbursement rate for the services is a very low one. And so we wind up being shortchanged in terms of the quality and the ability to take advantage of the technology. And when we look at pediatric ophthalmology and audiology, we have problems getting glasses for kids and hearing aids, particularly for children who are in poverty because they're not covered by their third party. We have real problems with access to pediatric ophthalmology for more significant concerns for children all over. Even something as basic as being able to get retinopathy and prematurity evaluations in the NICU is a problem for many children's hospitals. Academic medical centers, no problem. But when you go to children's hospitals and regional community centers, there's really nobody available to be able to provide that particular screening, which is so critical to long-term visual health. Nutrition and exercise physiology, we really are limited in the number of skilled nutritionists, particularly for children with developmental disabilities, particularly for children where the diet is the primary treatment. And so that whole issue of phenylketonuria and the ability to manage with an appropriate diet needs somebody who knows how to help to be able to manage that diet, and the access to those skilled folks is really limited. Similarly, bilingual access is a real limited factor. And our ability to stretch what we're doing out of the outpatient setting to more complex issues and provide the integrated nutritional services for children with intestinal failure who go through transplant, who have post-CNS radiation therapy following brain tumors. There's a real absence of resources in those areas. And interdisciplinary feeding programs, the ones that can really take the child with a severe developmental disability and move them from NG or JPEG feedings to be able to develop oral feeding techniques, they're really limited. There's one in Baltimore, there's one in Atlanta, and one is just developing Fort Lauderdale, and that's the entire East Coast of the United States where that access is available. And so it's a huge problem. I put it up. This is the brochure for the nutrition program. This is circa 1986. I want to make sure that this message of things change comes through. And then there's this issue of continuity of care across the lifespan, which we also talked about a lot as the concept of transition. And it's a huge problem for us. It was not a problem when I started my training, because most of the children with severe illnesses and severe conditions were not going to survive past their 21st birthday. So we didn't have to worry about what the adults were going to do to take care of them, because they weren't going to see them. And our internal medicine and specialists in other areas, they weren't trained to take care of childhood diseases in adults. So what we wind up having, though, is also a difficult issue. We think, well, okay, if it's a child heart condition, well, when they grow up, it'll be just like an adult heart condition. A congenital heart in a newborn that develops over a lifespan, the typical cardiologist is going to go, now, why did that blood vessel go that way, and exactly where is the aorta? It's not quite that bad, but it's close. And so we've got these developmental issues that present the adult physicians with dilemmas, because they really don't understand what's happened with the development over time. But and we also know that when we look at the research volume, we have phenomenal and growing research findings that provide us evidence about what happens with children, whether it's a child with cancer, sickle cell disease, Down syndrome, or whatever. We know a lot about early development. We know a lot about effective intervention and prevention, a variety of those things, and we're continuing to do more. We know almost nothing about what happens to those children after they become 21 and enter the adult world. So when we talk about evidence-based care for conditions of children moving into adulthood, we are kind of working in a dark closet. Funding models, hospital care restrictions may artificially restrict the smooth continuity of care. That's an environmental health issue that we struggle with all the time. Should we take care of a 29-year-old with Down syndrome, which is really a child developmental condition, who develops acute lymphoblastic leukemia, which is a known increased consequence in Downs, or has a cardiac problem? Do they get taken care of by the adult service? Do they get taken care of by the pediatric service? How do we cross cover? Those are logistic issues that are challenging for us. And the other component is that hospitals, when we need to have someone in the hospital, they're typically not organized to take care of people with intellectual or developmental disabilities. When was the last time that you walked the floor and you had a patient with cerebral palsy, with Down syndrome, with Fragile X, with an intellectual disability, with a genetic disorder, and there was a nurse there who knew how to do it, that there was an augmentative communication device so that you could communicate with the patient without having to go through a translator, so that you had the opportunity to sensitively respond to their questions and to assure that their fears were addressed, that you were able to assess their cognitive capacity to understand your directions to them in terms of what they needed to do for their care. Those things really don't exist. The resource challenges are huge. And if there's anything that's going to change, that's going to make my prediction that you'll be doing things differently in 10 years come true, it's this. Reimbursement for providers and hospitals is changing more rapidly than at any time in our history. Nationwide, the Affordable Care Act, for all of its benefits, is also causing rapid transformational changes in the way that care is being provided for. In my dean role, I struggle all the time about how do we pay faculty. Right now, most programs are the assembly line method. How many widgets are you able to turn over as they come down the line? That's called WRVUs. That's your measure of productivity. It's based on volume. Within 3 years, compensation for care is going to be based on outcome and value. That doesn't follow a widget model. And how we're going to do that, how we're going to look at productivity, it is very likely, great article this week from the Commonwealth Foundation, suggests that there are some programs around the country that are looking at this, and they're not compensating Jeff for being able to see 20 patients in a morning in his clinic. They're going to be compensating Jeff and Bob and Alan and whoever who form the team who take care of those patients, and they're going to compensate them on the performance of the unit, not of the individuals in the unit. And they're going to be compensated on the outcomes, not only healthcare utilization, but how well they do, and are they getting good care, and are they satisfied. And those are massive changes in the way that we're going to be doing our practice. We also are getting federal pressures. Fortunately, Congress and the White House agreed on a budget this week. If they hadn't, we were going to be looking at significant downward pressures on key programs, funding for the NIH on research, funding at the CDC for disease control and prevention, funding for the Title V programs that help to support us in so many of the things that we do. And here in Florida, well, we've got our own issues. Most states do. We tend to have more. We have hanging chads from the elections. We have other things. We decided to convert our Medicaid state administered to a managed Medicaid and put it in the hands of private companies. Well, some of those private companies are freaking out because they don't really know how to do this and they're losing money. And so we've got but Florida did something that was unique on this. They didn't just hand it over to managed care and say, manage costs. They actually have a penalty system. So if the company doesn't produce particular outcomes or fall short on the delivery of quality, they have to pay money back. They get penalized on the back end of their care. And so we have a model that is financially driving change, and the agents who are having to do that really don't know how to do it. And it's affecting every one of us at every level in our provision. Hospitals, we used to depend on hospitals. If you had a service that was coming through and you couldn't make any money on the professional fee side of it, you could always reach back to the hospital for program support because they were making, everybody knew, they were making lots of money. They were running a 6 to 10% margin on everything they were doing, and it was procedure based. Well, somebody figured that out. It used to be that if you had a patient in the hospital got paid for every day they were in the hospital. Now they have a DRG, and they say if you have asthma, you get 1.5 days in the hospital, and if you stay 3, hospital eats the other day and a half. And so those margins are shrinking dramatically, and in some cases, particularly in safety net areas, there's a risk that they can go under. And so there are these huge issues. There's an uncertain future for our children's medical services program. CMS was the model program for comprehensive wraparound integrated care for children with complex diseases and illnesses. But there's some real issues. It's not been funded. It's been changed. And even recently we have in the state a very significant issue where the state says they don't have the authority to provide the standards and do the reviews for certifying specialty programs in cardiology, and it may also apply to neonatology and some of our other issues. And these are critical standard and quality proposals that are there. And in Florida, we have had historically a huge wait list for Medicaid waiver services for everybody. Our research challenges are significant. Most of the childhood chronic and developmental conditions fit into the category of rare diseases. When we look at cancer, the lowest frequency adult cancer exceeds the incidence of all childhood cancers by more than 20,000 cases a year. It's a good example, and that applies to a whole host of our other diseases. Because of that, it's hard to do research at one institution. That means we have to collaborate across multiple institutions if we're going to drive the clinical trials forward in some kind of reasonable fashion to gain evidence that can affect our care. The models for how we do research, it used to be you were the PI in a lab and you were the director and you were the independent investigator, and now the model is you do team science. You bring in people who are different from you, who have a different perspective, and to collaborate. And it's a different model when you don't control everything as the PI. And so being able to learn how to do that team science is a critical issue. And the replicability of intervention trials and the research is really difficult. And that issue of translating what you find in a trial to a community practice as a standard of care is also a huge challenge, particularly because of the numbers. So at the Mailman Center, we have been, like many other centers, organized by silos. And that silo approach has been to clinical care and training and research. And I would say that this is true. We have issues here all the time because the Department of X says, well, we get to have this program, you can't have that program. If you have that program, we're going to have a fight. And it happens in medical schools all over the place. And we've had these same kind of issues here at the Mailman Center. We've also had a historic emphasis on the Mailman Center as the provider of services. We wanted to be the place that everybody came. If you go back to that earlier thing, we don't have enough people. And the volumes are so high, so we've got to come up with a different issue. Our research scope has been somewhat limited. It's been focused on discipline-specific projects, and we've had really limited ability to do that kind of collaboration that leads to team science. Our training has been more than 80% disciplinary and about 20% interdisciplinary over the years, despite our commitment to the interdisciplinary training component. And like many programs, we've judged our outcomes based on what activities we engaged in rather than on what impact or outcome we had. And so this was the reason that we came up with this strategic initiative for change. The driving principles, this is the repeat, innovation, doing things differently, leading rather than responding to market and policy changes. Impact, making a difference not only at the child family level, but at community and population levels. And connections, doing things together with both historic partners and collaborators that we've not considered before. And I'm not going to go through this in detail, but this is our new model. We've developed around interdisciplinary collaboratives rather than specific disciplines. And they're focusing on promoting positive behavior and development, neurodevelopment, and health and wellness, and lifespan approaches, recognizing that in each that area, groups of people from different perspectives can come together and work on training, research, service, and community engagement in a very collaborative way to have a high impact. This was Jeff back when he was in kindergarten. He's going to take that picture away from me. You look pretty good, Jeff. It's okay. As I mentioned, we've developed these interprofessional collaboratives in the 4 areas, and each of these will have the primary focus, but we also want to make sure that we don't, in doing this, create another silo of the Mailman Center with 4 groups. And so our IPCs are being charged with developing relationships across the Department of Pediatrics, with other departments in the School of Medicine, in the university, and with local, state, national, and international communities. This is a beautiful slide that Michelle put together for us that really sort of shows the process of engaging in outreach and advocacy, clinical services, research, and training, all leading to this impact on the community. You've probably seen this. If you hadn't, it's the concept of the translational science continuum. And it's the concept that we have basic and bench and animal research that helps to inform us about mechanisms and causes. We're able to use that to develop clinical trials to test hypotheses of improvement. We translate that into community settings and ultimately move it into policy. And at each level, there's a feedback loop. It's a great model. It's one that we're building into the Mailman. So what are the opportunities that we have to be able to address? One is to build collaborations with basic and discovery scientists to understand mechanisms of early disability and disease. The Mailman Center grew out of building a workforce to take care of individuals with developmental disabilities in community settings. And the concept of doing something in biochemistry or microbiology or genetics and genomics, it was pretty far-fetched at the time. But these are the issues that help us to be able to have impact. So new genetic models for newborn screening, followed by natural history studies to understand development conditions and opportunities of intervention, is one approach that helps us to potentially take those conditions that don't qualify for newborn screening now off the table, because we actually learned something in the natural history study that gives us an opportunity to treat. It's a fundamental issue. Clinical trials of innovative behavioral, developmental, pharmaceutical, or gene therapy interventions are on board. Who would have thought about the possibility that you would use gene therapy for autism? Jeff and I are engaged in conversations with the director of the Interdisciplinary Stem Cell Transplant, and it's a far-fetched idea, but the more we're working it through, it might actually have some feasibility. Because one of the things we've learned in our research here is that when we look at children who are treated for acute lymphoblastic leukemia using methotrexate, which is an antifolate, that close to 20% of those children 6 years after treatment will develop a cluster of symptoms on the autism spectrum and the social communication. And why? We think it might be because what we've done in treating and curing leukemia using a strong antifolate medication, we may have disrupted the folate pathway and the biochemistry of the brain and created a folate deficiency, which is tied to neurodevelopment. And it's that kind of connection at the basic science level that we want to be able to pull together, as well as new drug and treatment development. One of our adopted major goals of the Mailman Center, it's also being adopted by the University of Miami at a variety of levels, is to address health disparities, build capacity for children and adults from diverse backgrounds. Just because someone speaks Spanish or and has cancer, or speaks Creole and has cystic fibrosis, doesn't mean that that they will respond to our treatment, either because of the biomedical component of the treatment or because of the way we deliver it. Perhaps we need to be culturally sensitive and develop different treatment strategies. We need to promote disability as a diversity and potential disparity issue. When I think about health disparities, when I think about diversity, disability is often completely left off the radar, and being able to address that. Conduct health services research to assure that disparities due to care delivery models are eliminated. I mentioned that a second ago. Develop a pipeline of future professionals with both developmental disabilities and disparities training. We actually just got a grant from the Agency for Intellectual and Developmental Disabilities to do just that, to have our first disability fellow, and advocate for public policies that reduce barriers to non-disparate outcomes. Another opportunity is to build service capacity. We can't do it all, but we can adopt communities as partners for research, training, and implementation of best practice care. And we can empower and build their capacity to take care of their community in their community. We can establish data collection systems to use as measures of impact and outcomes so that we really know that what we're doing makes a difference. We can establish infrastructures for translation of center-based practices to community settings in an efficient way. The Debbie School here is a phenomenal resource. I've said this, Kathy cringes every time I say it, but the one thing that I love and hate about the Debbie School is it is the best early child care program for children with disabilities in the state of Florida or in the country. And we're acclaimed. Why would I hate that? Because it's not available in Homestead or in Opelika. We haven't figured out how to take the best and make it widely available. And that's a challenge for everything we do in pediatrics. And that involves using technology in many ways to find ways to more effectively use the technology experience to drive change. We have to develop a research mentality around all of our services. We have been a service-focused organization for many years, but we need to test what we're doing to see if it makes a difference. We need to use clinical observations to drive our innovative approaches to care, because they have to change. It's not good. No matter how good it is today, it's not good enough. We need to derive collaborations that drive translational discoveries and create mechanisms for team science and team care to change with these changes in healthcare reimbursement. And precision medicine is a big deal. How are we going to do that for children? What's the model for being able to use targeted therapies, precision medicine, using issues related to genomics, responses to drug treatment? How do we categorize children, and how do we administer that care? It can't just happen for adults. We need to promote innovative approaches to unmodifiable, and you see that I have that in quotes, social determinants of health, because we're stopped sometimes by the fact that we say, well, poverty is the greatest contributor to developmental problems, and there's nothing we can do about poverty. Well, there are things we can do about poverty. There are ways that we can design, and we need to be innovative in designing ways to optimize scarce professional resources. We need to assist communities in determining local solutions to increase green space, opportunities for physical activity, access to nutritional activities. Did you realize, this is my American Cancer hat, Society Cat hat for just a minute. We all know the contribution that tobacco has to cancer. It's about it accounts for about 30% of all cancers. Obesity related to nutrition and activity is associated with as many episodes of cancer in the U.S. as tobacco. It now accounts for 30% of the cancer burden in breast cancer, lung cancer, colon cancer, and a variety of other subcancers. This is a critical issue, and it starts in childhood. And we need to engage community leaders and programs to reduce the adverse impact of social determinants that may be specific to their community. Our next steps, our IPCs are working on getting their goals and implementation plans and coordinating across IPCs. We're going to be looking at ways to improve the efficiency and efficacy of our clinical programs and improve collaboration and integration with other programs at the University of Miami for core services. So we've not really been great at engaging child psychiatry. Neurology has been involved on a consult basis. ENT has their own audiology and speech program, and we have one for developmental disabilities. That's sort of crazy to be competing. Similarly, we have a department of physical therapy that we can work with, a school of nursing, nutrition programs, and behavioral science across the campus. And being able to bring those folks into our little program and make it big and reaching out is critical. But it also is recognized that there are other centers. There's the Interdisciplinary Stem Cell Institute, the Cancer Center, the Diabetes Research Institute, the Miami Project, our Clinical and Translational Science Award, to give us opportunities to expand our vision beyond this building and the things that we've historically done to be able to build toward that innovation. We have great core programs. Our Early Steps program, our Debbie School, the Child Protection Team provide more services to children than any other programs in the state of Florida. But we've not taken advantage of them as platforms to do research about the effects of child abuse and early child trauma on long-term development, on entry into juvenile justice systems, on long-term health-related problems. And so part of what we're doing is saying those are our research laboratories for many of the things that we need to do. We're developing strategic and synergistic research plans within and across IPCs that is inclusive of all of those levels of that translational spectrum. Now we're all having to learn because not all of us really understood that translational spectrum or how we were going to do it, but we're learning about it. We're designing and implementing new models of training that can be applied outside traditional learning settings. So how do we train parents, professionals, and self-advocates? If they're here, they can come here. What if they live in Quito, Ecuador, or in remote areas of Guatemala? How do we help to be able to do the outreach, to do the training there? And intentionally and effectively translate our center best practice into community settings, a huge part. Bottom line, the world of developmental disability and children with special health care needs and child health in general has changed and will continue to change. When I started working in childhood cancer in 1978, survival was about 30%. My first year here at the University of Miami, I went to 70 funerals. Survival for childhood cancer now is better than 80%. You don't go to as many funerals, and we don't hospitalize kids the same way. We're moving to much more outpatient therapy. We have bone marrow transplant as a primary curative plan for sickle cell disease, and I very, very seldom see a child with cystic fibrosis in a hospital anymore. We're managing them on outpatient, and we're going to be doing more and more and more of that management on an outpatient basis. So as a primary care pediatrician, you're likely to be doing things very differently than managing acute illness and infection or doing anticipatory guidance. And so the world's going to change. The Mailman Center can be a leader in using this change to improve the lives of children, their families, and the communities, and translating it to other people. So our final thought is it's really quite simple. Repeating it the third time. Embrace innovation. Strive for impact, and achieve success through connections. It really does work. Thank you.
So we have time for a couple of questions. Good. So my question is, we have a new university president. How does what we're thinking about at Mailman Center fit into what is likely to be the university's vision for innovation and change and impact?
I'd like to say that what we have here for our vision of the Mailman Center, we could just hand to Dr. Frank and have him just adopt it. And I think that there's a lot of similarity to that. Dr. Julio Frank joined us in August as our new president after serving as Minister of Health for the country of Mexico for 8 years, and then as Dean of the School of Public Health at Harvard before coming down here. And he clearly has articulated a desire to have the University of Miami be the major leader for global health, and particularly in the Western Hemisphere. And so many of these issues about figuring out how we reach out into communities, how we use technology, how we train, how we expand the footprint, what kind of research we do around health disparities. Those are all going to be highly consistent with the overall plan of the University of Miami. I couldn't be happier. Health disparities is becoming an issue for the state of Florida that is really critical. I've had the fortune for the last few years of chairing the Biomedical Research Advisory Council for the state, administering 2 of our grant programs. We developed a strategic plan, and the second goal of the plan is a reduction of death due to health disparities in colon, breast, prostate, lung, and I can't remember my other cancer right now. But we're focusing on reducing that. The focus of the Cancer Center here at the University of Miami is on health disparities. The focus of the CFAR program in HIV is on reducing health disparities, because that's the low-hanging fruit. And when we think about it related to children, if we can find that we have children where we have effective intervention and monitoring, and it doesn't work in subgroups, then the best thing and the fastest thing we can do to improve health of children is to take those groups that don't have access or aren't benefiting from that effective care and bring them into it and make sure it works. So I think we're going to be really aligned with President Frank. Alan?
I'm sure we all agree integrated interprofessional care is the model, and it's where we're all going. but we still practice every day on a fee-for-service basis.
Yes.
Using procedure codes for specific diagnoses. And it's just a real challenge. And how do you see this transition occurring over the next few years so we can get to that point where we're all being reimbursed for the quality at the end?
Well, yeah, I have roles here at the university at several levels here at Mailman, but with the dean and the provost related to just that question. Great article yesterday from the Commonwealth Foundation had a teaser, and it was how are health systems going to deal with transition and transformation. And then they talked about how they were going to pay under the relative value-based payment systems and all this stuff. They didn't talk about how you do the transition. And this is really about transition from one model to another and the change. And it's really scary, because if your entire financial base is dependent upon you get paid for the widget, and all of a sudden, if you shift to being paid for the outcome before people are going to pay for it, you go broke. But if you stay on the pay for the widget and you don't adapt to pay for the outcome, you'll go broke in 3 years. And so it's a real challenge. And Alan, I don't have the answer to it. It's one of the things that makes me wake up at 3 o'clock in the morning now. I used to wake up at 4, now I wake up at 3. And it's thinking about how do we do this transition? It is probably the biggest unsolved riddle. But innovation and connections will probably be the two things that will help us to solve it.
It also implies there must be a standardized set of ways to measure those outcomes that everybody would have to adopt the same, because you can't have people in one part of the country using one standard and another place using others. So that would also be a pretty interesting opportunity to figure that out.
And that's a great word. It's an opportunity to, in this area of change, to develop a leadership role to help with that transition. Yes.
Along those lines, I apologize that this is my question, but is
there are no.
Is the institution part of any ACOs? Because that's certainly one of the ways in which people are sort of trying to push for that.
We're not yet. And a large part of the issue, and this is true of many academic medical centers, it ties into Alan's question just a minute ago, is how do you transition to the ACO type model? The programs that are making the transition, many of them are institutions who have huge endowments. And so they have the resources to be able to fund the transition. Institutions that operate on margins, that as we are here, closely associated with a public health, public hospital safety net service, there's not a big margin. So figuring out how to do that transition just financially is the real challenge. What we need is the Gates Foundation to come in and underwrite health systems to make the transition. They're probably more likely to do it than Congress is, so it's a different issue. Any other questions?
Thank you again.
Thank you all.